Good morning. I'm Peter Rutherford. I'm the Chief Executive Officer for the Rural Doctors Association of Australia, and we're really proud to participate in the RANZCOG virtual conference. So welcome. Again, pleased to have you on board. This has been supported by our Destination Rural program, which has been really exciting for us over the last 2 years. Before we get going, I would like to acknowledge the traditional owners of the land that we meet on today and pay my respects to elders past, present and emerging. I'd also like to acknowledge any Aboriginal and Torres Strait Islander people who are joining our webinar session this morning, and thank you for your participation. Hopefully we've got an interesting and exciting, well, we think it is, webinar for you, really looking at rural maternity services, how they work, the good, the bad, and everything in between. We've got Dr. John Hall, who's the President of Rural Doctors Association of Australia and a very passionate rural generalist obstetrician. We've also got Dr. Nisha Kott, who is a Transcog specialist and works across rural and city-based practice, and is also a member of the Rural Doctors Association of Victoria board. My phone just rang. Thank you. Sorry for the interruption. I would like to now just hand over to Dr. John Hall, and he'll talk to you a little bit about rural maternity services, and we'll go from there. Thank you very much.
G'day everyone, great to be here. It's really exciting to be part of the virtual ASM and to be with you today. And I'm delighted to be joined by Nisha as well, one of our specialist colleagues who we know and love. I'm just going to bring up my slides and we'll get cracking. Okay, hopefully you can see that well. But yeah, as Peter said, today is a bit about rural maternity services. It's talking about the context of GP obstetrics and how we work with our specialist colleagues as well, but a bit about safety and context. This is just me, some of my contact details. You're welcome to contact me with any comments or questions for later. I'm going to talk a bit about a day in the life or a weekend in the life of a GP obstetrician straight off the bat. I mean, for me, this is some of the most rewarding work I've done as a clinician is working in a busy GP obstetric hospital. The context, the diversity, and the support and the teamwork, I just think it's some of the best work that you'll ever do. So I'll kick right off. I had a weekend in Cooma. This is only about 4 weeks ago. It was one of the busiest and complicated weekends in my GP obstetric career. I've been a GP obstetrician since about 2003. I did my Transcog advanced in Mackay and worked in Stanthorpe in southwestern Queensland for 5 years, and have done a lot of locum work as well. And more recently, have been doing some regular fly in, fly out work in Cooma about 5 to 6 days a month. On my last stint in Cooma, I arrived on the Friday day. I had an elective Caesar booked. This is the Caesar. I was booked to supervise the operator here. Her name's Emily Whitelaw. She's a fantastic GP obstetrician. Finished her Transcog about 2 years ago and has been working up in the Cape and the Kimberley. This is one of the first times in the Cooma context that she was working without an obstetrically trained assistant. So this was a bit of graduated supervision by exposure, and she did a fantastic job. But so I started off with this elective Caesar sort of supervising, and I did the baby resus, had a couple of my other colleagues doing the anaesthetics and assisting as well from Cooma. That's Sean Truder there with the glasses, and Brian Tugwell was doing the gas. Just some more pictures of us in action in Cooma. the other interesting part about this weekend, and again, when I say it was one of the busiest, on that Friday night, we had a multip come in, second baby. She'd been visiting from Sydney. She lived in Camperdown in Sydney, and basically was camping on Lake Jindabyne and went into spontaneous labour at 34 weeks, and was rushed straight to the hospital in Cooma, which is about half an hour away from where she was staying. Within 20 minutes of hitting the labour ward, she delivered her 34-weeker that ended up having pretty severe early onset group B strep disease and respiratory distress, and required manual CPAP. We manually CPAP that baby for about three hours while we were waiting for retrieval. That was the Friday night. That was my Friday. And then Saturday, busy with some other things. Then Saturday evening, we had another 33-weeker come in, Primip. A lady had some significant cervical pathology before and operative work on her cervix. Ended up in heavy labour at 33 weeks. We were doing the spec for the fetal fibronectin and saw bulging membranes. Popped the scanner on, and she had a footling breach. Or did a VE as well, like to assess, and could feel feet, and then popped the scanner on and confirmed a footling breach, and was an emergency Caesar at 33 weeks, again with respiratory distress and required surfactant before retrieval. I wanted to give you a brief summary of these cases because I think that weekend really strongly demonstrates the importance of rural maternity, and particularly with neonatal care as well, in that for both of these women with precipitous labours in our environment, had there not been a maternity unit close by, had there not been skilled midwives, the equipment to manage complex neonates, the ability to do the emergency Caesar, and that these cases are a lot more complicated than my summary would describe, but just for the interest of time, I wanted to give you a brief summary of these cases to really highlight the fact that it is so important that we maintain rural maternity units. And I think the outcomes in both of these cases would have been significantly different and significantly poorer had there not been a functional team there ready to go to manage. And also, I want to recognise the efforts and the good work and the support we got from the neonatal nets from the retrieval team as well. As you can see them there in this slide, setting up the CPAP, getting ready for transfer of this baby. And also we had the benefit and the instant support of the VCare, of the video link with specialist support while we were doing the initial resus and management of these babies as well. So it's a bit like an orchestra doing rural generalism. We're not experts in everything, but we have the clinical skills, the knowledge, the acumen, the ability to be able to basically work within that team to affect high level care on the ground. And it's one of the rewarding things about working and being a rural generalist. So that segues nicely into the next part of my talk, which is about the importance of rural maternity and what's actually happened in the political landscape in rural obstetrics in Australia. So since 1995, about 48% of rural maternity units have closed across Australia. That's 130 units. And that's significant, as you can see. We've also seen, when you look at the perinatal data from state to state, an increase in neonatal and maternal morbidity and mortality in those areas where we no longer provide maternity services. I'm showing you some Queensland data today because Queensland's one of the only jurisdictions where we've been given grainy access to some of this data. There's been a lot of political activism in Queensland around rural maternity over the last 20 years, and many of my senior colleagues have worked on this for many years and helped to set up an environment where we really brought it to the fore. But the reason why I'm showing you a lot of Queensland data is it's one of the only jurisdictions where they've given us open access to a lot of this data from a state point of view, and certainly want to acknowledge Queensland Health for their collaboration and cooperation with our research and into maternity services. This is a map showing you all the closed maternity services in Queensland since 1995. There's a couple on this map that have reopened, and it's one of the really, I guess, buoyant things and exciting things about being involved in rural health politics is that during my time involved in rural maternity advocacy and rural health advocacy, we actually did see a significant changing of the tide in respect to government's approach to rural maternity. And there's been 3 of these closed rural maternity units in Queensland reopened. So Bow Desert, Ingham, Cooktown, and they're working on Weeper at the moment. And there's a couple of others that are on a knife edge that the government is working hard on trying to reopen. It was always said that it was near impossible to reopen a closed maternity unit. And that's because you often lose your midwives, you lose your skilled doctors and nurses, you lose a lot of the equipment, and often you lose your operating theatre. So it can be very difficult to reinstate a closed maternity unit. And I think what's happened in Bow Desert is real proof of concept, and it's really exciting to be involved in the industry at this point in time where we're seeing a resurgence in support for rural birthing. And there's a lot of collaboration across, midwives, remote area nurses, Indigenous health services, and the Rural Doctors Association and the AMA in supporting this push back towards birthing closer to home, which is something that we think is a basic human right. It's a really important cultural milestone, and many of my Indigenous doctors colleagues have heightened the issue to me about the concerns around birthing on country or not being able to birth on country for our Indigenous community as well, which is not insignificant. And for me, I think it's a no-brainer because we see clinically poorer outcomes when we remove services. And I think, for us, we've always looked at things like emergency care, cancer care, quality primary care, and access to maternity and birthing as essential basic human rights for rural people. And we've got one of the best health systems in the world. The main sort of blight on our system in Australia at the moment is it's poorly distributed, that we do have one of the best health systems, and the way that we could probably have the best health system in the world would be if we could work out a better way to distribute equitably the healthcare that we provide for Australians. I touched on, the difficulty of reopening birthing services. It's such a linchpin. We talk about a mantle of safety. It's been described as sort of the cornerstone or the keystone in services. When you remove birthing, you remove theatres, you remove rural generalists with skills in anaesthetics and acute care and obstetrics, and often the hospitals where you've removed these rural generalist services become downgraded. They have a lower level of capacity when it comes to acute care for general medicine and emergency, and obviously losing elective theatre for the community as well. It's a tragedy when we see these services being downgraded and changed, mainly for the community in terms of their access to care. This slide is actually really interesting. It's looking at the community impact. So there's a community impact index, which is based on the rural birthing index, which is also an indicator that we use around planning which sites, which rural sites should birth and which shouldn't birth. I'll go a bit more into this as well. What we fight is a community perception that it's not safe to provide these types of specialist type services in rural environments. And we often fight that within our own profession, that there is this perception. There's a perception that it's unsafe to provide these services. For me, I find it really difficult to understand and believe that as a medical community, we would say, well, in the bush, we're going to provide cardiac care, we're going to provide cardiology, we're going to provide emergency care, we're going to provide internal medicine, we're going to provide primary care, but we're going to section out the whole of obstetrics and gynecology and say, sorry, this community can't have that, or it's not safe to provide it. In the context where we have published data that shows that it's actually very, very safe to provide maternity care if it's done correctly. Also, you know, we've had a lot of politicians commit to the concept of providing maternity care for rural and remote Australians. We have a universal service obligation. The Australian healthcare agreements as well all talk to this, and there's been multiple iterations of things like the National Consensus Framework on Rural Maternity, where governments have committed to providing maternity care locally. There's also been a lot of published data in Australia and overseas around the safety of low volume birthing. Again, this flies in the face of a lot of perceptions in the general community, but also within our profession. And this study by Tracy et al. Was one of the landmark studies that looked at the safety and perinatal outcomes in small units, and they found that neonatal death was less likely in hospitals where less than 2,000 births were being delivered regardless of parity. And they're not insignificant statistics. I have a theory on, you know, that there's lots of sort of conjecture as to why, you know, why this might be the case. One of the reasons is that we risk stratify, and we appropriately risk stratify, and we move high risk women, you know, to the city to birth electively and wait in those sort of environments. But also, I think that in many smaller units, you're getting a lot better continuity of care, you're getting one-on-one care, you're not having multiple births happening at the same time. So I think women do enjoy more sort of one-on-one attention, and we have the luxury of sort of time to spend with women and make decisions where we're not pressured and not dealing with multiple cases at the same time. So I think there is something real about the safety of smaller units and less busy units. This is a study that was published in Australia based on the Atherton statistics. It's nearly 20 years of data now. I know these are old figures, but it was a very big study, a longitudinal study that showed that in a functional maternity unit where you had GP, rural generalists, GP anaesthetists, GP obstetricians, that the perinatal mortality was significantly better than the state average. And across all indicators like Caesar rates, induction rates, and the like, the indicators are certainly much better. And again, no maternal deaths in the 20 years of that study. This is not a published data, but this is, we do grainy analysis. We did grainy analysis of the Queensland data year on year at the Rural Doctors Association of Queensland conference. And when we pulled the perinatal data from our rural areas, you know, again, you could see the comparison in terms of metro and rural across these indicators. This is raw perinatal data. This is not interpreted. This is not manipulated. This is raw perinatal data. What we did do, and in part of this, we also showed that in areas where maternity services were closed, in geographic areas where maternity services were closed, the perinatal mortality rate went up significantly. But the significance, I guess the statistical significance of that is in question. But anecdotally, you know, we did see significant increases in perinatal mortality in areas where maternity units had been removed or closed. There's been subsequent reviews in Queensland around this, where they did a review of maternity services in rural and filed a report. Unfortunately, what we saw there and what we see through the ABS and Australian Institute for Health and Welfare, when they analyse perinatal data, what they tend to do is group the whole of rural together. So when you group the whole of rural together, the bad outcomes from remote areas where there are no services are grouped together with the better outcomes from the the larger units where we do have functional units, and they come up with an average which tends to be worse than the city. So when you look at published data from ABS and AIHW, again, the community gets the perception that it's less safe in the country. I would put to you to look at the individual safety in functional rural generalist maternity units when you're looking at whether or not it's safe to do this. And you can see, you can see from the numbers that there is safety in the numbers. I'm going to leave it there, and I'm really excited to hear from Nisha. One of the things that underpins our safety working as rural generalists in rural hospitals is the backup and support from our specialist colleagues, which is essential and invaluable. I've worked in units where I've worked in rural sites like Broome, and I know there's other sites like Catherine and Alice Springs where specialists work alongside generalists. It's also a really interesting and rewarding context to work, but we certainly need the support from our regional specialists, and we fought hard as the Rural Doctors Association to support regional specialists as well, being able to practice generalist medicine in the regions, and we certainly, there's certainly a need for our to have a good cohort of generalist specialists in the region supporting rural generalists, and for us to work closely together as a team. So I'll leave it there, and I'll hand over to Nisha.
Thanks, John. That was really good to hear the statistics, because everything looks more understandable when you can actually look at the numbers and try and make sense of those numbers. So I'm going to actually talk about what does a specialist do in a rural setting. The reason I'm talking about that is because after working in Australia in sort of metropolitan Melbourne for about 5 or 6 years, I first took on a rural role at Bacchus Marsh Hospital. Now, I don't think there is anyone in maternity care in Australia, New Zealand, or in fact across the world that hasn't heard of Bacchus Marsh Hospital by now. You have to have been living under a rock to have not heard of it. But when I started at Bacchus Marsh, my kind of take on it was maternity care is maternity care. It doesn't matter where you provide it, you're still delivering babies and you're still doing the same thing. And that I quickly came to realize was a very naive point of view. And it was a very naive point of view being somebody who'd always ever worked in the city. Although I had worked in sort of the suburban hospital, so I had not at that point worked in a tertiary hospital. So there was a bit of understanding, but not exactly the sort of context that it takes to work rurally. And so that has been a steep learning curve of realizing that actually staffing, distance, facilities, support or the lack of support, community engagement, safety, quality, governance, and our city colleagues or our regional colleagues play a huge role in keeping a rural maternity service going. Now, you may or may not have heard of something called urban-splaining. It's essentially a phenomenon that describes where somebody who is urban, possibly in a tertiary center, explains something to a clinician working in a rural setting in a slightly condescending and a slightly overconfident manner. So the first time I made a phone call and said, well, I have this woman and she has a placenta previa and I need to transfer her. She is 37 weeks. And I got a response that said, oh, can't you do a cesarean section for placenta previa? And every instinct in me wanted to say, well, actually, I can do a cesarean section for placenta previa. You have a Transcog, I have a Transcog. We went through the same training program. We learned the same surgical procedures. We can both do the same surgical procedures. However, the context of where I am, it would be the wrong thing to do. It would be the wrong thing to do a placenta previa cesarean section in a small unit with no on-site blood bank, with a GP anesthetist providing the anesthetic. And so that sort of context of where I was and what needed to kind of be an explanatory conversation was what triggered this interest of why rural maternity care is so important. And I firmly believe that my colleagues who are in a city hospital or in a regional hospital don't have any malicious intent, because I'm one of them as well. So I work part-time in a big tertiary hospital and part-time in rural medicine. So I can understand that there's no malicious intent. They are sitting in the middle of a labor ward that is heaving, bursting at the seams. Women are birthing left, right, and center. It's like a war zone. And so their response is coming from a place of, we're really busy and we can't cope with that. But the flip side of that is that the more maternity units close, where are women going to go to birth? They're going to have to go somewhere. And so that birth suite that is bursting at the seams will burst beyond those seams very quickly once the rural maternity units close. And so it's up to us as regional clinicians or city clinicians to actually provide the support that will help rural clinicians to keep a service going. What happened at Bacchus Marsh was that once we took on the role of, having specialists provide services, very quickly the GP-led obstetrics service died down completely. And so that is a real shame, because the GP obstetricians also had a general GP practice in the town, and they were the ones who had seen women throughout their lives and then had a role in birthing their babies and then looking after them postnatally. And that sort of continuity of care, which we know improves outcomes, there's no doubt about it, was lost in that sort of change from being a collaborative service where GPs worked with specialists to a specialist service where specialists came in, did their 2 days a week or 3 days a week, and yes, provided good care. I mean, we're all there to provide good care, but what was lost was that continuity and the context that women had and the relationship that women had with their providers of maternity care and providers of general health care. And so that is a shame. And I think as a college, RANZCOG is very supportive of not just having Transcog trainees, but also having Transcog and advanced Transcog trainees, so that we can continue to have that collaborative approach of doing things together rather than getting into what I see as territorial wars almost. There is no territory. It is maternity care. We're all here to provide it, and we are all here to do it together. So I just want to go over a few things that as a city-based clinician or as a regional clinician, you might think of doing to support colleagues who work rurally. The best thing I can say is that, what are some of the simple things to do when your rural colleagues call you for help? You can actually help. That's as simple as that. Have a collegial relationship, try and understand the context from where they're calling. And of course, you can't have context for every single rural location, but your rural colleagues will provide you with that context. Give them support and advice that is helpful. Don't go down the route of urban splaining or tertiary splaining, because that is unhelpful. The person at 2 o'clock in the morning in a small rural center needs just somebody to say, okay, let's do this, and this, and that will help. The other thing is taking a week off from your busy city schedule and taking a week and helping somebody out as a locum in a rural service, getting that sort of first-hand, hands-on experience, win-win for everyone, because your rural colleague gets some time off and you get to experience a completely different system that you may have last experienced as a trainee maybe. And things have changed in rural Australia. And so you might get a pleasant surprise of what can be done in a rural maternity unit. The other thing might be getting involved in training and education. So in Victoria, the Royal Women's Hospital runs the Maternity Simulation Education Program, which is basically a mobile simulation education program. Midwives and obstetricians, and I'm one of them, travel out to rural units and run a day of simulation of obstetric emergencies and sort of go over what has changed, if anything has changed in the guidelines. And often nothing has changed. Things are all the same. It's just about reinforcing teamwork, reinforcing escalation, reinforcing that collaboration between different teams, which makes people feel like they have had some sort of training and some update of their knowledge and skills. And this can be done in a variety of different ways. And with COVID, I think that one of the advantages is that we don't even need to travel out. We can do it remotely and support our educators who work in rural locations to provide that training themselves. The other thing you can do is help with RCA, so root cause analysis and governance things. Again, the Victorian way of doing it is to register yourself for a panel of external expert reviewers, who can then support this governance process in a rural unit. My one tip is to go into it with an open mind, because if you're going from a city, you need to then have the context of a rural place without putting a city hat or a city context into the outcome that you are reviewing. So again, these are all, very simple things that all of us can do. But I think the most important thing we can do is that we are all involved in training junior doctors. And when we train junior doctors, just like parents, when we are at home, everything we do is watched by our children, and our children take on all those subtle things that we may not say, but we show in our actions. And our trainees take on all the subtle hints that we drop about rural maternity care not being as good, not being as rewarding, not being as, important. And those are the sorts of things that trainees, who are essentially, in a way, our children they're imbibing things from us. And so if we have a positive attitude towards rural maternity care, our trainees will pick it up from us and will go out, whether they finally end up in rural maternity care or end up in the city, they will always have a positive attitude towards it. They will always have an attitude of collaboration. The other thing you can do very easily is provide opportunities for rural clinicians to stay updated and stay abreast of any advances by having the opportunity to work with you, whether it's in your private practice or whether it is in your public practice, whether it advocate for it within your hospital, for a rural clinician to spend maybe a week every 3 months, every 6 months, getting their surgical skills up, getting their knowledge up, getting to know how things are done, what has changed, what is different, what is new. That really helps in updating skills and keeps rural clinicians in the loop. Plus, it helps making those relationships. Someone you work with, you're more likely to respond positively to than a stranger at the other end of the phone. So I think this is all a win-win situation for city-based or regional clinicians. You can feel morally superior about having supported rural maternity care, and your rural colleagues can feel good about having a relationship with you, as well as getting their skills, knowledge updated and having your support, whether it be with education and training or whether it is with governance and safety and quality. I'll leave it there and we'll get to some questions.
Thanks, Nisha. John, we have got some really good questions from the attendees, so that's fantastic. And if anyone wants to put some more questions into the Q&A, please feel free and we'll get to as many of them as we can. There is one about the, neonate training for diplomats. So I guess, John, to you, how important do you think it is to have those neonatal resuscitation skills as a diplomat in a rural setting?
Oh, look, it's absolutely essential. And for me, some of the most challenging clinical scenarios I've dealt with have been neonatal, not maternal. And when you're working in a big city hospital and you can call peds and, you just hand off the baby. When you're working in many rural maternity units, you are the baby doctor. And at the end of the day, you've got to have those skills. It's not negotiable. There's a lot of standalone, as we know, neonatal resus courses, which we recommend. Most jurisdictions these days require that for ongoing credentialing. Credentialing is one of the big challenges for generalists, because we call it the alphabet soup of credentialing. We've got to do all of these EMST, APLS, and all of the courses to stay credentialed. But certainly it's an important part of diploma training. I think there could be more clinical exposure during diploma training to, say, doing a NICU term or being more of the peds doctor. There's a real cultural divide in large hospitals that I witnessed during my career, where if you're labelled as one specialty, it's almost taboo for you to step across the divide and be the baby doctor. But breaking down those barriers as part of Transcog training and being given the freedom to be the baby doctor in a Caesar or a resus, get some experience in NICU, more firsthand would be good. I do remember in my Transcog exam, there was a neo resuscitation, which was welcome. And I do sort of welcome Judy's comment that they're trying to work on beefing up neonatal training within the Transcog. I think it's important, and it's certainly welcome, and it's essential. You're on mute.
Thank you. The question of the day. I know when I was at Kingaroy, we actually supported one of our midwives and one of our GP obstetricians to go away and become a train the trainer in neonatal resus, so we could actually create some sustainability and ongoing support locally for that, to develop that skill for the team. I'm going to put this question to both of you. Nisha, I might start with you first about how we can better mentor and support diplomats into rural practice. So what are your thoughts on that?
Like I said, it starts with when they are in their training program and having that positive attitude about mentoring and encouraging people to go into rural practice. But over a lifetime, I think it's time that we made those relationships very clear and very formal between the regional and city centers and small rural hospitals, where you can thereby encourage rural clinicians to take a week out of their busy schedules and spend it in a regional center or in a city hospital, so that they can update their skills, and that will give them the confidence. Plus, it can be very alienating, especially if you are really far away from a regional center, to feel like you're the only person there, and there's nobody keeping an eye on you, nobody checking up on you to see if you're okay or not. And so building those formal relationships really is the key to making sure that we mentor more rural clinicians. And that's not just maternity, that's across the board, whether it's pediatrics, whether it's anesthetics or any other specialty.
John, what are your thoughts on that, about how to get into diplomats?
As Nisha said, it's so important that our specialist colleagues are supportive. I remember in my training, I had a number of my specialist colleagues say things to me in metro hospitals like, why would you go rural? It's a dead-end career and don't do this. I had a lot of really supportive mentors as well, but I mean, at the very least, it's important that people don't talk it down, particularly if you haven't experienced it. As I said at the start, for me, it's like some of the most rewarding work I've done in medicine. It's really interesting and rewarding. And different, and particularly if you're a personality that likes generalism, so it can be really rewarding. I think we really do need supportive specialists that understand the context and support us. So when it comes to things like upskilling, I've had different experiences as well. I've been to some larger metro and regional hospitals where I go back as a senior GP obstetrician clinician to do upskilling, and you're treated like a junior registrar. You're not given access to procedures. You're sort of treated a bit like a leper in the department, where you're a generalist amongst specialists. And we really do need that support. So if someone comes to your department and they're doing upskilling, encourage them to get as many Caesars as they can, encourage them to do things, get into labour ward, be able to do some instrumentals, to do things, not just to be seen, treat them like a medical student, having them sitting in the background, just, because, our experience and exposure, our upskilling is actually essential for our ongoing safety, and we really do need that support. I really like what Nisha said about building relationships. So that relationship between your receiving hospital, your closest receiving referral hospital, and the doctors on the ground, it's really important to build that up. And I would echo what Nisha said about regional doctors or metro doctors going out and visiting some of these sites and experiencing, what it's like on the ground. And also understanding the geography as well. Often there's a lack of understanding of geography, about retrieval times, about the capacity to move people, and also professional trust. So I think that's really, really important, that if I have a clinical opinion, that's also respected and trusted as well in the grand scheme of things. So I think that sort of wraps a bit of that up. But I think if the more supportive and collegiate we are together, that respect goes both ways, the more likely we're going to have doctors wanting to work in this context.
Just further to that, one of the questions has come through about should we reintroduce GP supervisors mentors for Transcog trainees?
Oh, look, absolutely. I'll talk to this because I personally had a fantastic experience as a Transcog trainee. I was mentored by none other than the Judy Gardner, who's on the federal board of RANZCOG, and was my GP obs supervisor in Mackay. And it made a huge difference having a GP obstetrician working in a regional centre alongside specialists for me to learn context when I was doing my Transcog and working, doing Caesars with Judy and being mentored in the context was really, really helpful. So I do think throughout my career, what I've observed is that the number of GP obs working in regional centres has gone down as the number of specialist trainees has gone up. There's been less and less opportunity for GP obs to work in regional centres. And I think that's a real shame because, again, it breaks down that working relationship and building those relationships between specialists and generalists. And I do think it's really important to have the generalist context and the culture of that imbued in regional centres.
Okay, Nisha, I'll direct this one to you to look at maintaining or, reintroducing birthing to some of these small rural communities. Is the answer midwifery-led models, backed up by medical referral or retrieval?
Peter, I think there are far too many battlegrounds in maternity care, and there needs to be more collaboration and less battlegrounds. And those battlegrounds are, the GPO versus the specialist, midwives versus obstetricians, and collaboration is the key to it. And yes, maybe midwifery-led units are the answer, but midwifery-led units still need somebody to provide a kind of overview and to provide some sort of a referral process, if you like. So if something abnormal is picked up from the midwife, there still needs to be a process where there is a rural clinician they can refer to before they refer the woman on to a regional or to a tertiary center. And so there is a layer there that we shouldn't bypass. And, yes, of course, midwives are part of this whole team and we should work collaboratively with them. And absolutely, if we decide that midwifery-led units are what we should have, we still need to have a layer of rural generalist obstetricians who can provide the support to midwifery colleagues.
John, is there anything you wanted to add to that?
Oh, look, I like calling it collaborative care or collaborative models. I think we've got some great examples around Australia and rural of essentially midwifery-led units that are heavily supported by their GP obstetrician colleagues, where it just works. And we as GP obstetricians, one of the challenges is often being on rosters where there's only one or two of you or three of you, and you're doing 1 in 2, 1 in 3 on call. What we need is highly functional midwives that are happy to do the normal, and we're happy with that. And we're happy to be coming in and supporting when there's pathology. Historically, a lot of GP obs units have had policies where the doctor has to come in for every delivery. And I think in some ways that's been a barrier because it creates a workload that's unsustainable. And, midwives are experts in the normal and we're experts in the pathology, and we should be utilising the skill sets that we have appropriately and efficiently to run rural units. So, I mean, I'm a big fan of, midwives suturing peris, dealing with the normal and calling us when they need. When you hear the term medical model, often there are a lot of nurses that actually buy into that. So a lot of the sites where I've worked and we've tried to work with the nurses to extend their scope or to say, oh, the doctor might not come in for this birth, it's actually the midwives that go, no, we want you to come in. So I think we need a culture change across rural practice where we support, midwifery-led advanced midwifery practice. But remembering that it's not just doctors that drive the old medical models. It's actually the whole system is set up to be that old school medical of the doctor doing everything, and it's really not sustainable in rural.
Thanks, John. Thanks, Nisha. So it's actually quite topical. There was a bit of a grab in the Australian on the weekend about GP obstetrician or Transcog registrars actually doing like a mandated rural training and cultural training. So interested, I'll go to you, Nisha. The benefits, the negatives, I think there's, arguments on both sides, but interested to hear what your feelings are. And then John, I'll come to you as well.
I'm not a fan of mandatory anything. I hate mandatory competencies. I hate mandatory credentialing. Mandatory just makes it another tick box exercise. And that has never worked in the history of getting people to do things, for people to actually do things well. And so instead of mandatory, what it needs to be is an encouragement. And so if we show trainees the positives of going rurally, and part of that has to do with the fact that they are likely to be in situations where they will get a lot more independence than they would ever get in a regional or a tertiary center. They would probably get a lot more surgical experience because there's a lot of surgery that is done rurally. That will actually be the sort of carrot. Use a carrot, don't use a stick.
I agree, Nisha, and I think that's our approach to rural recruiting and the rural workforce issues generally. There's a lot of politicians that think we should have geographic provider numbers and mandate, doctors having experience in the country. And look, we know we've got a saleable product. It's, as I said, I keep saying it's one of the most interesting jobs you'll ever do, rewarding from a community perspective, from a whole range of perspectives. So we've got a saleable product. We just need to sell it and market it and give people experience. We know from research that people that get positive rural exposures actually often go back and work in that environment. And what's lacking in our system at the moment is the ability to give people positive rural exposure, funded, supported programs to give people those elective exposures, which we need to build on. There was a program in Queensland where registrars rotated through the flying obstetrician and gynecologist. They had a flying obstetrician gynecologist service in remote Western Queensland that used to fly around to different rural sites and do gynae lists, but they'd also back us up with complex obstetric cases. And there used to be a term where you could go as a registrar and work with the GP obstetrician who was the flying obstetrician who was a specialist. And the reports back from those terms were amazing. Like the people that I know, I've got specialist colleagues now that did those terms and they were training and absolutely loved it. And it actually did create specialists that really understood the geography and understood the challenge of working rurally. So I think it's a very positive suggestion, and certainly we would support it. But we do need to come up with ways of funding and supporting and encouraging people to do rural terms.
Okay, we've also got an interesting question. We've touched on the need to have, a good midwifery team supporting rural generalists as well as specialists. But we've also got a question about the need for a functioning nursery, and that at the moment, women are getting sent away because the baby may need a nursery. So how do we advocate for that? What are the benefits? And, are you working in rural facilities with, fully functioning nurseries, or nurseries that are, purpose built, or is it something on a more of an ad hoc type basis?
John, I'll let you go first.
Okay. Look, I think this is a really important issue. And I think it comes to risk stratification and what support services we build in units, both from a logistic point of view and a workforce point of view. I don't like the term low risk units or low risk anything. We know that in obstetrics, as you saw with my weekend, I had 2 very high risk cases thrust upon me without any election. That wasn't my choice. It wasn't the woman's choice. Risk changes and escalates in obstetrics on a dime, and we need to have units that are prepared to deal with complex cases. And when healthcare administrators build a unit and say, oh, this is a smaller unit, it's low risk, therefore we don't need this piece of equipment or that piece of equipment, or we don't need to staff it fully, then I think it's fraught with danger. One of the things that low risk or lower risk units or low volume units need to do is to be able to respond to high risk when it happens. So if you remove any exposure to risk, then you de-skill and you end up with more, I think, risky and dangerous situations where you have a team that's not necessarily as skilled or up to date with managing that. So I think the whole concept of you know, over risk stratifying and also creating units where, you know, you've got a hard cutoffs for this many weeks or hard cutoffs for this and that, creates this environment where you then sort of, you know, you're not going to be funding and building your nurseries. I'm not really sure the context that the questioner is asking about. I suspect it's sort of more regional, large, you know, smaller regional hospital or larger regional hospital where they've got a lower level NICU. But, you know, I think the concept's the same across all of these units, that you need, it's really important that you have the capacity. I'll give you an example. Like, we had to do hand CPAP for 3 hours waiting for retrievals to come, and the cost of a CPAP device that you could use and strap on is not very expensive, but we didn't have one in our nursery because it's not deemed, you know, that doesn't happen enough, or you don't need it. But I mean, yeah, so my view is that you know, anywhere where you're delivering babies should have all of the equipment and all of the setup and services, and you should, you know, have access to staff that have the skills to manage it as well.
All I will add is that if we can avoid separating mothers and babies, that is a win for everyone. And often the separation occurs on sort of not very good clinical reasons. For example, a baby needs IV antibiotics, and so we don't have a nursery here, hence the baby must be transferred. But that to me seems like a thing that could easily be fixed. Giving babies IV antibiotics doesn't need a huge amount of training or skills or equipment or anything like that. And we could easily fix that. So yes, we should advocate for special care nurseries and sort of the big ticket items, but there are some very simple things that we could work
Absolutely.
on and, you know, go with the small wins first.
Just on that, Nisha, I think one of the problems here is often staffing, and smaller units have got, you know, skeleton staff. And often the justification that's been used to me is, oh, we can't keep this baby because we would need to have a nurse special, and we don't have, you know, they're often, it's not that they don't physically have the body, that unit's not budgeted to put a person on. I think in smaller units or lower volume units, they need the capacity for surge workforce and the ability in the budget to say, okay, for this case, we are going to have to employ another nurse or two for this shift. And the ability to flex up and flex down, not to say, well, this is our establishment and we're not going to be able to move from that. It's one of the things that you notice working in rural is that you can have 2 weekends where nothing happens, and then you have a weekend like I did where 3 or 4 complex things happen, you know, within 48 hours. So, you know, you need that redundancy, and I think you need that ability to flex up and flex down. And often administrators and, you know, people, you know, running healthcare budget and hospital budgets don't factor that in.
I'm going to finish with one final question. And Nishi, this is probably a good one for, well, it's good for both of you, but you'll have first-hand experience. I guess one of the things we hear a lot from our members, particularly rural generalist obstetricians, is in relation to when there is a bad outcome. And obviously, what we've seen in recent times with the case that happened at Bacchus Marsh, and prior to that, what happened at Bundaberg with Dr. Patel, that rural doctors, and particularly rural generalists and GP proceduralists, came under a lot of scrutiny because of certain bad outcomes. But what we found was actually specialists working in these services. So I guess I want to put to you, do you think that, you know, a bad outcome in a rural centre is managed in a similar way or treated as fairly in the process as what bad outcomes that happen in major, you know, tertiary or regional centres? They're just, yeah, interested in your observations. And John, I'll put that to you as well before we finish with final thoughts.
The short answer, Peter, is no, they are not treated the same way. A couple of things play into that. The first thing is that often small rural units don't have as much of a dedicated sort of investigative or governance staffing, whereas a regional or a big tertiary hospital would have a whole department dedicated just to making sure that all the governance structures are in place, all the guidelines are updated, everyone's completed their whatever mandatory training, and to make sure that every single sentinel event is recognized for one and investigated properly, whereas rural units just don't have those sort of backup systems. And so often sentinel events sometimes fall through the cracks because there isn't a dedicated ability to be able to learn from them. That's one thing. Secondly, yes, we do see that there is a perception out there, and again, it's statistics. You can, twist statistics the way you like. If you really wanted to, there is a perception out there that rural healthcare is badly managed, and things like four corners and whatnot don't help that perception because they don't put into context some of the really fantastic work that happens in rural healthcare settings. And so it's incumbent upon all of us, specialists and generalists, to make sure that we celebrate our wins and talk about our wins. It's also the fact that often the specialists who go into rural practice are people who may not have worked in the Australian context, may not understand what that context is, and so may not be, sort of performing the right procedure, right place, right person sort of thing. And so in that situation, I think there is a role for the system to play in making sure that a new person is orientated to their location. And so, like I said, I had worked in Australia for 6 years before I went to my rural job. And even then, there was a lot of learning to be done. And so having someone who arrives and their first job is in a rural location is challenging for a variety of reasons, not the least being the fact that they may not know the capacity of a system to be able to support what they're doing.
John?
Oh, look, I think this is a really, really important point. And I think when this is managed poorly, it actually is a huge barrier to recruiting and retaining rural generalists in practice. I've witnessed personally across my career a number of colleagues who've been unfairly vilified for bad outcomes, only to live through a lengthy investigation and be exonerated, but treated really poorly in the process in a system that's meant to be not blameworthy. The whole process of things like root cause analyses, if done poorly, can be very blameworthy and can be, really stressful and soul destroying. I've seen careers ended by this type of behaviour, and it's really important that people involved in these processes understand the context, that it's proper and appropriate peer review, that we're not dealing with sent elsewhere opinions. I'll give you a quick example. I had a surgeon friend, a GP surgeon, had his FRCS from the UK, was working as a GP surgeon, did a laparoscopic cholecystectomy in a rural facility. 1 year later, the patient presented to a tertiary hospital in the city with abdominal pain and what was thought to be a complication from the surgery. That surgeon, the surgeon that saw the patient in the metro environment, made the comment in his letter that it was likely a complication from the surgery. That surgeon got stood down from his position. So the rural surgeon was stood down from his position until the investigation played out. And, and it was a clip that had come loose that was an expected or known consequence of that type of surgery. I'm not pretending to be a surgical expert here, but long story short, when the investigation played out, it was very clear that it was an expected complication, that in fact it was nothing to do with the surgical technique, that doctor stopped practicing surgery. So that town lost a surgeon over the 2 sentences written by a specialist in a letter. An opinion based on no fact. So I think it's really, really important that we support each other. And I think it's important that there is strong clinical governance when we're looking at rural complications, and that, we've always said that we want rural generalists and rural clinicians to be measured against the same standards. We're not saying we want lower standards, we want the same standards, but we want that to be applied really fairly and equitably. And we need to look after our clinicians who are quite vulnerable.
All right, I'll spend the last 20 seconds just thanking our panel members, Dr. John Hall and Dr. Nisha Kott. Thank you to everyone who joined, and enjoy the rest of the RANZCOG virtual ASM. Thank you, everybody.
Thank you. Bye.
Thank you.